Hi there, fellow physiotherapists. I am Helene van Aswegen, your host for Physiotherapy Trauma Talks, where we discuss everything related to trauma care. So if you are passionate to learn more about physiotherapy in the field of trauma to ensure that you provide the best possible care for your patients, then this is the right podcast series for you. Today we are discussing pain and pain management in trauma, and I am joined by Professor Romy Parker from the University of Cape Town in the Department of Anesthesia and Perioperative Medicine and the Director of the Pain Management Unit. Romy, thank you for joining me this morning.
Thanks, Helene. It's great to be here. I'd love to talk about your book.
Thank you. So, Romy, won't you tell our listeners a little bit about yourself and how you ended up in pain management?
Sure. So I might be in the Department of Anesthesia and Perioperative Medicine, but I'm still very much a physiotherapist. And physios have an enormous role to play in pain management because pain is the ultimate biopsychosocial construct.
Yes.
It's complex. It's about human beings. And as physios, we've got multiple tools to engage with people when they've got pain, you know. And I got into pain management because I was working in the field of rheumatology. And you would think that when people have joint damage and joint disease, that all our treatments should focus on the joints.
Yes.
But then I met patients who had terrible joint disease and no pain. And patients who had very mild joint disease and terrible pain. So I started asking myself the question, kind of, what is pain then? Because it didn't seem to be directly correlated to the joint disease.
Yes.
I got into pain and understanding that pain is not directly correlated to tissue damage. That pain is something that our brains create when our brains come to the conclusion that we're in danger.
Okay. Yeah.
And sometimes the joint had something to do with it, but a lot of the time it was all the other things going on in people's lives that contribute to pain. And I think in your field, in trauma, the same applies. You know, we've all seen people with awful polytrauma, but their pain doesn't seem to be that bad.
Exactly.
And then the person in the bed next to them doesn't have that bad an injury, but they've got screaming pain. You're like, what's going on? And that's what fascinates me about pain. And what draws me to it as a physio, because as physios, we're good at engaging with our patients, right?
Yes.
And seeing the whole person and thinking about getting them back to living their lives. And pain management is all about that.
Yeah, definitely.
Yeah.
So when someone has a traumatic injury, it's often very unexpected in nature. So what do you think would be important for physios to understand in this context of unexpected injury inflicted on the body?
I think it's so important, Helene, to think about the fact that if somebody has been hospitalized because of a traumatic event and it was unexpected, it's the equivalent of the worst day of their lives, right? So if you think about stubbing your toe, we've all stubbed our toes, right? Agony. Okay. But if you stub your toe on a good day, you know, it's a beautiful day, you've got all your friends and family around, everyone's brought food, there's wonderful music, everyone's talking and enjoying each other's company. As you walk outside, you catch your toe on the door and it does that.
Yes.
That's sore, but how long does it hurt for?
Probably not that much,
And you get back to being with your friends and your family pretty quickly and it's okay.
Yeah.
But what about stubbing your toe on a bad day? You know, when you've worked 2 weeks in a row because everyone else has been off sick and the weather's terrible and had the worst fight ever with the person you love the most in the world, and you're just not sure why you have to get out of bed and go to work again today, but your bank account's in a miserable place and life just feels overwhelming and it's all terrible, and as you walk into the bathroom, you catch your toe on the door and it goes, how much does it hurt?
Yeah, no, very different perception of pain.
Completely different experience. It's not just the pain, but I mean, I sat on the floor and cried for half an hour once when I stubbed my toe because it was a bad day.
Yeah.
And it was so painful. And it's not just that it was so painful, but when you were having a bad day, we're also pro-inflammatory. So you have a bigger inflammatory response. Your toe might swell up on that day.
Okay.
And it didn't swell up when you were having a good day.
Yeah.
Yeah. The tissue issues what happens in your toe might be exactly the same on those 2 days, but pain is about more than the tissue issues.
Yes.
So we think about somebody who's having trauma, we've got to think about more than their tissue issues, right? Yes, we've got to pay attention to the tissue issues. Don't get me wrong. Don't ignore that. But who's this person? What are they worried about? What are they scared of? Who's supporting them? What are the consequences for them? Does this mean they're going to lose their job? Maybe they don't know and they're worried about that.
Yeah.
Did their cell phone get smashed in the car and they haven't been able to speak to anybody that they love since it happened? What are all the other things contributing to it being a bad day?
Yeah.
And that's holistic biopsychosocial pain management.
Yes, no, and I think it's so important that you mention those things, because often in the trauma ICU setting or even a busy trauma ward setting, we as physiotherapists don't always think about asking these additional questions when we first meet and assess our patients. So, yeah, very important to keep in mind.
I mean, we don't necessarily need to do a 20-minute history taking, because that's not appropriate and relevant, but just 1 or 2 questions of how are you doing? What are you worried about?
Yeah.
How are you feeling? When it hurts, what worries you about the pain is a critical question to ask in that environment. Let's say someone's got rib fractures and it's sore for them to breathe deeply, but I need them to breathe deeply.
Yes.
And I know it's safe for them to breathe deeply. They need to know that although it hurts, it's not dangerous.
Yes.
So asking them, when it hurts, what worries you about that pain? Let me reassure you that that's not dangerous. It's safe for us to do this. Even though it hurts, can make a significant difference to it actually hurting.
Yes, that's very true. So let's talk a little bit about the neurophysiology around pain. So we know that there's several role players, which is your peripheral nervous system, the spinal cord, the brain, and then the
others.
The
others. We've taken to calling them the synergistic systems, to give them a little umbrella name, because they all feed in.
Yeah. And we also know that there's terms like nociceptive pain, neuropathic pain, and
the other one.
What is it? Nociplastic pain.
Nociplastic pain. Yes.
Could you maybe just talk about all of that?
All of that.
Yeah.
All of that. So, when we experience pain, particularly trauma pain, we're talking here about nociceptive pain, all right? So nociceptive pain is pain that's arising because the nociceptors are firing. What on earth is a nociceptor? So noci has its root in noxious. Okay. So a nociceptor is a receptor, a nerve that fires when something potentially noxious, potentially dangerous is happening.
Okay.
All right. So nociceptive pain is pain that I'm experiencing when something potentially dangerous is happening in my body, or if I've had an injury, something actually dangerous.
Yeah.
Okay. It's important to remember that they fire for potential danger. Everyone's experienced that. If you put your hand on something hot, right? Sometimes you get that, ow, but you look at your hand and it's not actually burned.
Correct, yeah.
So brilliant. The pain system did its job. It set off the alarm so that you didn't get burned.
Yeah.
It's really the point of a pain system. It's a protective system, okay? It's not a tissue damage measurement system.
Yes, okay.
Okay. So nociceptors are firing because something potentially dangerous has happened. If you've had trauma, something actually dangerous has happened.
Yes.
Okay? So the nociceptors are firing in the peripheral nervous system. They come along and they deliver the message on the spinal cord. If the message is loud enough, the spinal cord hears it and sends it up to the brain. Nociception gets the brain gets nociception. 200 different parts of your brain interpret all of that information, not just the nociception. Your brain also goes, where are we? What's going on? Has this happened before? Ooh, do I remember anything dangerous? Do I smell anything? Do I see anything? Do I hear anything? What do I know about this? Puts it all together. And if your brain comes to the conclusion that you're in danger, it generates pain. Okay. And that's nociceptive pain. So you bang your funny bone, you stub your toe, you cut your finger. That's nociceptive pain. It's not always painful though. Sometimes you cut yourself and you don't notice, right?
True.
So what happens then? So what happens then, we think, is that you cut yourself, the nociceptor sends a message to the spinal cord goes, yeah, okay. Sends the message up to the brain does the processing and goes, we're in the garden. Julian loves the garden. The birds are singing. It's a beautiful day. Don't worry about that danger signal. It's fine. So nociception comes in, but your brain might go, in the bigger picture, we're not in danger. It's fine.
Okay.
What happens later, Helen, when somebody goes, you're bleeding, and you look at it, what happens then?
You get a fright.
And
you think, oh my goodness, I need to do something about it.
And does it hurt?
Then it might.
Sometimes it stings then.
Yes.
And it's a bit confusing, right? You're like, you didn't hurt a minute ago, but now you're stinging, and now I need to do something about this.
Yes.
Right? What changed? What's changed is your brain's got more information now. Now you've looked at it. You've seen the blood. Someone said blood. Now your brain's got information. Oh, maybe that is dangerous.
Yeah.
Oh, maybe Helen does need to do something about this. Hello. Have some pain. That gets your attention, right? Pain interrupts us, interferes with what we're doing to get us to change our behavior. And so then we wash our finger, put a plaster on it. We're all good. Okay? So nociceptive pain is probably the most common pain that we're going to see in trauma.
Okay.
Okay? Because those nerves are firing and the brain has decided we're in danger. Then we have neuropathic pain. You're also going to see that in trauma. Neuropathic pain is pain which arises because of pathology in the nerve.
Okay.
Okay? So the nerves get damaged. We see that, right? Neuropathic pain when nerves are damaged occurs because those danger nerves now start firing spontaneously, like little electrical bursts. Ding, ding. So neuropathic pain, how do our patients describe it? Electrical shooting, pins and needles tingling, burning. Down here in Cape Town, my patient says Dorf pain. It's kind of numb, but it hurts.
Yeah.
That kind of Dorf pain.
Okay.
Yeah. That's all pretty typical of neuropathic pain. Yeah. And it's not that I moved the rib that it hurts. It's just that the nerve next to the rib got a bit irritated or inflamed and it's firing spontaneously.
I see. Yeah. Okay.
And my brain receives it as exactly the same as the nociceptive message. My brain doesn't know how to tell the difference. It just goes, ow. That's neuropathic pain.
Okay.
Nociplastic pain, probably less relevant in the acute trauma situation, unless somebody had a pre-existing nociplastic pain condition.
Okay.
But where we do need to pay attention to nociplastic pain is if we're not managing people's acute traumatic pain appropriately, we're really increasing their risk of nociplastic pain.
Right.
Okay. So nociplastic pain is when the whole nociceptive system becomes so sensitive that it starts setting off the alarm despite the fact that nothing dangerous is happening.
Okay. So I can see the difference there. Yeah.
You can see that straight away, right? So just flexing and extending my elbow might be painful despite the fact that there's no tissue damage. It's healed. It's done all right. Okay. We might get nociplastic pain with somebody who's had rib fractures, healed. You know, we're 3 months down the line. We've got beautiful evidence of tissue healing. They're doing fantastically, but they still hurt with coughing and sneezing.
Okay.
Okay. That is because the nerves in that area have become sensitive from the injury, which they should, but they haven't desensitized with the healing.
Okay, so there's still that background pain the whole time.
That background sensitivity, the alarm keeps going off, going, oh, careful, we're vulnerable here, careful, when actually there's no need for it to be careful. So it's plastic. Okay. The plasticity has changed of the nociceptive system.
Okay.
Okay?
Yeah.
So those are the three kinds of pain. And all the way through, we always think to ourselves, when someone has pain, what's going on in the peripheral nervous system? What's going on in the spinal cord? And ultimately, what's going on in the brain?
Yeah.
Because it's the brain that creates pain.
Oh, yes, of course.
No brain?
No pain.
No pain.
Okay, that's really interesting. So in relation to trauma, how is the timeline regarding tissue healing defined for the acute period of pain, subacute, and chronic?
Great question. And it links to what I said just now. Someone had a rib fracture more than 3 months ago, right? So timelines are really important. And timelines are important because of tissue healing times.
Okay.
So I always say that my students, I know you learned this in first year or second year, see if you can remember it. So tissue healing phases, your first phase of tissue healing, the inflammatory phase, okay, tends to last 10 days to 2 weeks. If somebody's got severe polytrauma and maybe a lot of comorbidities, it may last a little bit longer than that. But typically around 2 weeks, we transition out of the inflammatory phase. Okay. Inflammatory phase peaks at 72 hours, which is something everyone forgets. So if it's bad on day 1, day 2 is going to be horrible. Okay. 72 hours, it peaks, settles down, and by 2 weeks, we transition out of the inflammatory phase.
Okay.
So in the inflammatory phase, we've got lots of pro-inflammatory cytokines around. Okay. Immune systems. Up. What's your endocrine system doing in the inflammatory phase? Big sympathetic nervous system, big cortisol release, lots of save Helene activity going on, right, in that inflammatory phase, okay? And all of that sensitizes the nervous system. So the peripheral nerves get very sensitive, spinal cord and brain all get very sensitive. So in the inflammatory phase, pain is severe. Okay. And it's not necessarily directly in relation to the amount of inflammation we can see, because there are all of these other synergistic factors going on that might be adding to somebody's pain. Okay. Then we move into our second phase of healing, tissue regeneration phase. And that lasts up to 6 weeks.
Right.
Okay. And those are the first acute inflammatory phase and tissue regeneration phase from 0 to 6 weeks, where there's lots and lots of cellular activity, lots of stuff going on, okay? But pain in that second phase, between 2 weeks and 6 weeks, gradually settles down, okay? Now, when pain is behaving the way we expect it to with tissue healing processes in that first 6 weeks, we call that acute pain.
Okay.
I kind of think of acute pain and nociceptive pain as pretty much mirroring each other.
Yes, okay.
It's pain behaving the way you expect it to, doing the things that you want it to, protecting you when the tissues are vulnerable. As the tissues heal and become more robust, the pain settles down.
Yes.
Yep. The third phase of healing, 6 weeks to 3 months. We regard that as the subacute phase. That's your tissue remodeling phase. You remember remodeling from fracture healing, right?
Yeah.
Okay, so at 6 weeks, we've got union, but from 6 weeks to 3 months, we've got remodeling. So there's still stuff going on. And pain in that phase, not necessarily there all the time, but if you push the tissue hard, it's going to go, oh, we're not strong enough for that yet. You know, it's still a little bit sore, okay? And again, that's normal, and we regard that as subacute pain, okay? Again, a nociceptive pain.
Right,
okay. But 3 months is the magic line. Okay. 3 months is when most tissues in the body are healed, Helene. Finished. Doesn't matter if it was a slip disc, fractured tibia, surgery, 3 months, most things are healed. We're done. We're good to go. Okay. So if you still have pain after 3 months, we call that chronic pain. And that's not normal, healthy pain. That is essentially nociplastic pain.
Right.
Okay. That is pain where the system has got stuck being sensitive, despite the fact that it doesn't need to be sensitive anymore. Because the tissues have healed.
Yeah. Okay, wonderful. Thank you for that beautiful description. You touched a little bit on the synergistic system. And could we maybe just talk a little bit about what that is made up of and how that influences pain?
Okay. So, you know, you talked about pain as the neuroscience of pain. We're now talking about the psychoneuroimmune pain mechanisms, recognizing the synergistic systems. And to make it kind of manageable, the synergistic systems that I encourage people to pay attention to are the immune system, the autonomic nervous system, and the endocrine system. Okay. And if you think about managing trauma in the intensive care situation, those three are big.
Yes.
Right? So we know that if somebody develops an infection or has come in with an infection, their pain will be worse.
Definitely, yeah.
Okay. And one of the reasons why we encourage people to monitor pain as the fifth vital sign is that if you start seeing temperature spiking and pain spiking, you've got an infection on board.
Yeah.
All right. Whereas sometimes when you see a temperature spike on its own, sometimes my anaesthetists are saying, oh, maybe that's just a post-anesthetic spike.
Yes.
Right? But if you see it going with pain, you've got an immune system that's kicking up into gear. You've got lots of TNF alpha, interleukin 1 beta, all of your pro-inflammatory cytokines, immune system cascade kicking in, and that is going to push pain up. Okay? So pain is useful then to tell you what's going on in the immune system, but also don't be surprised if you're treating somebody for, a fracture, and then they've got a bladder or respiratory infection, their pain is worse.
Yes.
It doesn't mean something's gone wrong with the fracture.
Yeah, and I think that's important to remember.
Really important to remember. So I had a patient years ago who had this chronic knee pain, and she phoned me and said, I've done all my homework and my knee's so bad. Please, can I come and see you? And I was, yeah, sure. When are you coming to well, I've got this terrible bladder infection, so I've got to come to the UTI clinic tomorrow. And I said, you know what? Let's get the bladder infection under control and see what happens to your knee. And a week later, she's like, my knee's fine. So it's really important for us as physios to remember that if there's another infection going on in the body somewhere and I'm rehabbing something that has pain, that pain may be worse. And it's not that I've got to back off on my rehab.
Yeah.
Yeah. Remembering that. Autonomic nervous system. Oh, in ICU, doesn't it do some funky things?
Definitely.
Right? I mean, you know this way more than I do, but some of the autonomic dysautonomia things that happen when people have had long stays in the ICU, or even a short stay, but 3 or 4 days ventilator support, you start seeing that autonomic disruption going, right? Okay. So if you're seeing autonomic disruption, if you're seeing unstable blood pressures, or you're mobilizing your patient and they're dizzy and they're all over the place, or you're seeing some of that bladder sensitivity starting to kick in, those kind of autonomic nervous system disruptions, their pain may flare up as well.
Okay.
Not because of the injury, but because of the autonomic nervous system.
Yes.
Right? And then endocrine system. Just keep it simple and think about stress. Okay? If I'm stressed, cortisol, endocrine consequences.
Yeah.
Okay? So anything that's going to disrupt the endocrine system is going to also sensitize neurons.
Okay.
But we know long-term ICU, food, diabetes, all of those endocrine disruptions that we see when people are on that kind of support in the intensive care may also then contribute to their pain, because the endocrine system and all of that cortisol cascade links in with the nervous system.
Okay, and the experience of pain.
Absolutely.
Yeah. One other thing that we will leave as a topic for discussion for another episode is sleep and sleep quality in the ICU, and particularly in the trauma ICU as well, and how lack of sleep impacts on pain experienced and several other things.
Hugely.
So is sleep quality also part of the synergistic system?
Absolutely.
Okay.
So we particularly think about sleep in terms of autonomic nervous system.
Right. Okay.
Right, and your parasympathetic.
Yes.
You don't get any parasympathetic balance without good sleep.
Yeah.
We used to think the relationship between sleep and pain was bidirectional. So when you're in pain, you don't sleep, and if you don't sleep, you get more pain.
Right.
Right, and off it goes. But actually, the recent evidence from our colleagues at WITS is that sleep drives it.
Okay.
So if you're not sleeping, that's the bigger driver of pain rather than pain disrupting sleep.
Okay, that's
so
interesting.
sleep is a primary focus in appropriate pain management.
Okay.
And I relate to that. I mean, if I've stayed awake for 72 hours, I have fibromyalgia. I'm in pain all over my body. I can't think. My memory is gone. I'm miserable and grumpy and in pain. And that's what sleep deprivation does for pain.
Okay. Yeah.
So not sleeping in the ICU, that disrupted sleep, really problematic.
Yeah, definitely. So in the ICU context, we know that pain management during this acute phase of pain is often driven by pharmacological management, like opioids paracetamol and several other methods of managing pain. But coming back to physiotherapy, what do you think would be the role of a physiotherapist in that context?
Enormous. Okay, so the first thing is, if we're recognizing that pain is something my brain generates when it perceives that I'm in danger, then the physio has an enormous role to play in creating a sense of safety with the patient, right? And we all do this, right? We all make sure we make contact with our patient. Hi.
Yes.
My name's Romy. This is who I am. This is what we're going to do today, okay? But then the next thing is, before you just start doing your rehab with them, is to say, how are you feeling? What are you worried about? Is there anything on your mind that you'd like to chat to me about? What questions do you have? What are you scared of? Okay? And being very clear that in my physio session, that at any time they can say stop, that actually they're in charge.
Yes.
Yeah? To give them that control. Because one thing that we know about pain is that if we have pain but we feel like we're in control of it, it doesn't bother us that much. Okay? But when we don't have control of it, that's when our distress goes through the roof.
True.
Okay? So if you think about having a sore tooth, if your tooth is only sore when you stick your tongue in it, you don't go to the dentist. Well, I don't go to the dentist. It's only sore when you stick your tongue in it because you're actually in control of it.
Yeah.
When you go to the dentist, when it's sore all day and all night and you don't have control of it anymore, you go to the dentist. Right?
True.
And the dentist says to you, why didn't you come to me months ago? This has obviously been going on for long. Yeah, but it wasn't bothering me that much. Okay? So if in the ICU setting as a physio, I can give my patient some sense of control. They might not have control of the bigger picture, but give them choices and a sense of control of what's happening and what's going to happen next. That then gives them a bit more control over the pain and reduces the threat of the situation. Okay? So communication strategies and how we engage with our patients make a huge difference.
Yes.
Okay? Then we have treatments. We have tools in our toolbox.
Definitely.
Touch, cold, heat, TENS. Some lovely new evidence coming out on TENS.
Oh, that's great.
For acute traumatic pain, for perioperative pain management. In fact, in Europe and in the UK, TENS is now part of post-operative pain management.
That's brilliant.
Right?
Yeah.
So lots of things that we can do. And how great is TENS actually? If your patient is conscious enough and is able to have the power and control of their TENS machine, that's also going to feed into how well they respond to that pain management.
Yes, and I think in the ICU context, that would be absolutely wonderful to be able to introduce to them. So I'm glad you mentioned that there's new evidence coming out for that specific modality as a pain management strategy post-operatively. You mentioned earlier in our discussion that it's important during the acute phase of injury that we as physiotherapists ensure that we manage pain adequately so that it doesn't escalate into chronic pain later on.
Yeah.
So if we think about strategies that physiotherapists can use in order to ensure that we are aware of the patient's pain experience and that we manage it appropriately, any thoughts about that?
So I think my first thought is sometimes as physios, I think we think that if we treat the tissues and the injury, the pain will get better.
Yeah.
But it's important for us to treat the tissues and treat the pain separately. Okay. Because it's a conscious construct of my brain.
Yeah.
Okay. Where do we start? We start with pain is about threat. So who's the person in front of me? What do they think is wrong? What are they afraid of? What are they worried about? Okay. So that cognitive reassurance, okay, is really important to reduce pain.
Okay.
What's also really important to reduce pain is validating someone's pain.
Yes, and I think we don't always do that well.
Yeah. And validating someone's pain doesn't have to take hours and doesn't go on forever. You know, I think sometimes as physios we're worried that if I spend ages going, oh, I'm so sorry, it's so terrible that I'm never going to get into my rehab. You know, I'm just going to spend my whole session handing out tissues. But validation of someone's pain doesn't take long. I can see that this is really sore. I'm so sorry that this is happening to you. I can't imagine what it must be like for you. Okay? But here's what we're going to do to make this session manageable for you.
Yeah.
Okay? So it's just a genuine touching down, if you like, of validating someone's pain experience.
Yeah, and that you can do within a minute.
Exactly.
Yeah, no, that's
like
true.
30 seconds to 1 minute. It doesn't take long, but just sitting with it for a moment and going, I know this is sore and I'm really sorry this is happening to you.
Yeah.
And being genuine in that is really important.
Yeah.
Because I don't know about you, but when I've been a patient in the hospital setting, and people ask me about my pain and I say it's an 8 out of 10 and they just nod their heads and write it down, my reflex is, but it'll be a 10 just now. Did you actually hear me? It's kind of, I'm sorry, that was really, I'm telling you, it's quite bad. I need you to get it.
Yes,
right?
to acknowledge that.
And sometimes we're being so professional and there's so much going on in our heads that we don't give the acknowledgement of it.
Yes.
And that's really important.
Yeah.
Yeah.
Okay.
So treat pain separately. Treat the person.
Yes.
Pay attention to what they're afraid of. Validate their pain. Yeah. And then plan your treatment to address pain perhaps before you mobilize them. So put an ice pack on and give it a good 10 to 15 minutes before you mobilize them.
Yes.
Or put the TENS on and give it a good 20 minutes before you mobilize them, or leave it on while you're mobilizing them.
Okay.
Right? So thinking about the tools that you have, get the extra pair of hands so that you can support the patient. Teach the patient some mindfulness techniques, some mindful breathing techniques to use while you're doing other rehab with them, right?
Yeah.
So empower them with the self-management strategies. If you've got somebody who, you're going to be working fairly passively, give them some virtual reality to engage in while you're doing that, okay? Yeah. Because that occupies the brain and distracts it, and now it's not worrying about the danger stuff that's coming in, because I'm having a good time, So think about addressing the pain. What can I put in place before doing my physio?
Yeah.
And then if they are on analgesics, drug treatments, making sure that they've had the analgesia before you do your thing, and that it's working, Yeah. It's like, how many minutes ago did you have that medication? Let's just wait a little bit until it gets to its optimum dose before.
Yeah, I think that's very important, definitely. Just coming back to mindfulness therapy, there's one method called imagery. I think I'm right, where you ask your patient to visualize how they would do a certain activity.
Yes.
And I suppose that would also be useful in this context of pain and trauma and trying to mobilize and get active within all of this that the patient experiences.
Very useful. And imagery is useful for two things. So one thing is that when I imagine myself walking down the beach, I'm actually firing my premotor cortex, which then helps me fire my motor cortex. So if I'm about to get my patient out of bed and walking and they haven't for a long time, it's useful for them to imagine walking first.
Yes.
Because they'll do it more smoothly.
Yeah.
Okay, it comes more easily. But imagery is also useful because it's a distraction technique. Now, when I say distraction, I'm not meaning just, don't think about it. I mean actively engaging your brain in something else so that it's not busy fretting about this danger thing that's going on. Okay. Some precautions, though, are needed with imagery. Don't give your patient an imagery. I might say to you, let's imagine walking down the beach at sunset, but you were mugged on the beach at sunset a couple of years ago. That's not going to be relaxing for you. So ask your patient, where's your favorite place to be? Tell me about it. Can you imagine yourself there? And then use the senses. What can you see?
Okay.
What can you smell? What can you hear?
Okay.
Can you taste anything? What can you touch?
Right. So bringing in those senses.
Bring in the senses and immerse them in that imagination.
Okay.
And that helps to ground them. It's a grounding technique, which then reduces the threat evaluation in the brain.
And the fear of movement, I
Exactly.
would think. Okay.
Exactly.
And you would do that before you then get them to do their knee flexion exercises or standing up with a frame and walking.
Right.
Okay. And I suppose what we've spoken about is very useful to use in patients who are awake and responsive, but those that are not awake in the ICU, I think it's important that physiotherapists are just more observant of any signals from the person that they are experiencing pain.
Completely.
So facial grimace or a sudden retraction of a limb due to what you've been doing to that limb.
Exactly.
Because there's so much evidence out there to show that patients are at different levels of depth of sedation. And often,
what is consciousness?
Exactly,
Yeah.
And often, you hear stories after the ICU experience where patients say they recognized a particular voice. They were aware of discussions around the bedside, but they just couldn't respond to it.
And imagine if they recognize that particular voice and they know what comes next.
Exactly.
It's like that voice means that's the physio. What's happened to the threat level in my brain? The physio hasn't even started and the brain's on high alert.
Yes.
Of course that physio session is going to be more painful.
Yeah.
And I think with those patients, some strategies that we can use is talking to the family. What music does this person like?
Okay.
What's their favorite place to be? And so that while we're treating them and engaging them, we might have that music playing.
Yes.
Or we might talk to them about, I hear that, you love going to the beach. While we're moving your feet, why don't we think about walking down that beach?
Yes, I think that's
thinking
great.
about engaging in that way.
Yeah, and I think the engagement with a patient that is not able to respond to you is so vitally important, because we often see physios walking into the ICU and never talking to the patient that seems unconscious or not able to respond to them. So it's really important that that communication takes place anyway, whether the nurse is laughing at you or not.
Yeah. Or we're laughing at ourselves. And I think also it's helpful for us to be talking to that person, even if they're not responsive, for us to remember that we're treating a person.
Yeah. And of course, in all of this, just to come back to the trauma aspect, to know what the precautions for movement are.
Absolutely.
To have discussed it with a surgeon and the rest of the multidisciplinary team in the ICU, and to be really sure of that you know what you can and can't do.
Absolutely.
Yeah.
And that's why, when you said to me what can the physio do for pain, or where do we start? It's that I've got to treat the tissues. I've got to know what the injuries are and what's safe to do and what my precautions and contraindications are.
Yeah.
I must know that.
Yes.
But then I must treat pain separate to
Exactly.
that. Okay.
Yeah.
And I've got to treat pain and know that pain is not an accurate measure of all of those tissue issues.
Yes. Yeah, and to keep that in
separate.
mind. Yeah.
Yeah.
Okay. Romy, as a last comment, anything that you want to mention, or are you happy that we've covered everything?
I think that one of the key things that I want to say to physios is that the non-pharmacological treatments for pain are where it's at.
Yes.
In modern pain research and where all of the research is going and where clinical development is going, the drugs, yes, there's ongoing research in what drugs we can use for pain, but they have minimal effect. They just turn down the volume a little bit. The things that really make a difference is what we do as physios, is engaging with people, is reactivating them, is getting them moving, is helping them engage in meaningful life roles and doing the things that they love and enjoy. And so, in your ICU trauma setting, partnering with the occupational therapist,
Yes.
working together and working with the person, we can make a massive difference.
Yes. Yeah, no, that's very true. Thank you so much for your time. It's been wonderful to have this discussion with you.
Thanks, Helene, and thanks for having me.
You're welcome.